Hello, everyone. My name is Carlos Zamora from the University of North Carolina at Chapel Hill, and today I will be talking about traumatic orbital emergencies. I have no disclosures. This presentation will be a focused review of key patterns that we encounter in practice, and I'll walk through some of the most important injuries that affect the orbits in the setting of trauma, and I will try to highlight what to look for on CT, and we are going to discuss some potential imaging pitfalls. Traumatic orbital emergencies are common. This is something that we deal with every day when we read cases from the ER. And the issue is that findings may be subtle, they can be easily overlooked, but the potential impact is high if you miss a diagnosis or our interpretation results in a delayed diagnosis, that you can have important consequences. CT is a primary modality for trauma. We do not need contrast unless you suspect that there's a vascular injury, that there might be infection or neoplasm. And because this is a small structure, the orbits are small structures, then we need thin slices. At our institution, we use 2 millimeter axial, coronal, and sagittal planes using a combination of bone and soft tissue reconstructions. But we also add a 0.75 millimeter bone reconstruction that we can use to evaluate for subtle fractures. And we can also use for to do our own reconstructions at the workstation, at the PACS station if necessary. Now, remember that not all foreign bodies are hyperdense. Here we have a very obvious nail, which is hyper attenuating with some artifact in the right orbit. But here we have another one in a different patient that is mostly radiolucent, that this is a piece of wood. And it's important to be descriptive as to where the injury is. And here you have the non-contrast CT. And here you see that we gave contrast, right? Because we were concerned about vascular injury. You can see how the piece of wood went through the superior orbital fissure, and after contrast, you can see that it's abutting the internal carotid artery. And on the coronals, you can see your optic nerve there. Luckily, this patient was saved from major injury because it did not affect critical structures, but it's important to be anatomically descriptive. This is a typical case of a blowout fracture. And this happens most commonly in the floor of the orbit. As you can see here, there is displacement of the fracture fragment. This is a very thin area and the weakest portion of the orbit, um, followed by the medial orbital wall. And in this case, you can see that there is herniation of fat contents from the orbit into the maxillary antrum, and there's herniation of the inferior extraocular muscle as well. This is the second most common site, which is the lamina papyracea or medial orbital wall, as you can appreciate here. Now, this fracture is a little bit more difficult to detect because this works as some form of trapdoor mechanism, right? So the fracture opens up, but then closes back down, and then you might not see it. Here, you do see it here, right? But the tip here is that you have this small amount of tissue in the maxillary antrum that if you pay close attention, it has fat density. So this is not a retention cyst. This represents a small amount of herniated orbital fat that is within the antrum. So that could be what tips you into looking more carefully for the presence of a fracture. This is a different patient with a blowout fracture on the left side, and you can see that there is herniation of orbital contents into the maxillary antrum, as well as the inferior rectus muscle, right? So you have fat and inferior rectus muscle, which is very deformed, right? This is a patient with extraocular muscle entrapment. If you suspect it, you have to mention it in your report. However, please remember that entrapment is a clinical diagnosis. It is not something that we can reliably determine on imaging alone. But if you suspect it, it is important that the patient has a adequate clinical examination to evaluate for it. Now, this is another important fracture pattern, the naso-orbitoethmoidal complex, that has important implications. It represents a pattern of fractures that involve the nasal bones, the nasal septum, the ethmoid sinuses, and the medial orbital walls due to a large force that is applied over the front mid aspect of the face. And there are several issues that can occur as a result. One is disruption of the lacrimal apparatus. Here you can see that the right lacrimal duct is posteriorly displaced, and that can lead to repeated tearing of the eye or epiphora. You can have mucocele formation. The other potential issue is that you can have rupture of the canthal ligament, and that will result in telecanthus. So that will need surgical repair. And you also have an increased risk of CSF leak. Another important aspect to consider in the orbits is that because they are closed compartments, is that the presence of any hemorrhage behind the globe has the potential of leading to compartment syndrome, orbital compartment syndrome, that may put the optic nerve at risk. Here you can see this patient with retrobulbar hemorrhage, right, which is hemorrhage behind the ocular globe, like you can see here, and see how the optic nerve is stretched. So this is potentially a problem. This is a patient, different patient with a somewhat different type of hemorrhage. This is a little bit more contained. You can see that it has somewhat of a cone shaped. And this is hemorrhage in the subtenon space, which is the space between the tenon fascia, where you can see here in pink, and the eye. Right. So this is a little bit more contained, but it can also result in increased mass effect in the posterior aspect of the globe. You can see that the optic nerve here is stretched. And here's another example of a patient where I am not showing you the entire extent of the injuries, but you can see that there is proptosis bilaterally, there is stretching of the optic nerves, and there is also tenting of the posterior aspect of the globes bilaterally. So these are globes that are at tension and at risk of developing orbit compartment syndrome. And the risk here is that they could result in ischemic optic neuropathy. Now let's look at some detachments. Here are typical cases of retinal detachment on this patient, and which is typically in the shape of a V. And why is it shaped like a V? And that's because the retina ends right here at the level of the ora serrata, right? Where it joins with the ciliary muscle, right? Or it meets the ciliary body rather. And that's what gives it that V shape. And in this patient, you also have a dislocation of the lens. See how it just it's prolapsing into the vitreous chamber. Now, choroidal detachments are different. They go all the way anteriorly. And the choroid is this vascular layer that you can see here of the eye that contains connective tissues and lies between the retina and the sclera. It goes all the way anteriorly. That is why choroidal detachments have this shape, or that is more um, like a baseball, different than the V shape of the retinal detachment. Now look at this child with abusive head trauma. You can see that there is subdural hemorrhage on the right side and a little bit along the falx. And if you pay close attention to the eyes, you have a little bit of hemorrhage along the retina bilaterally. And this is something that CT is not sensitive for it, but sometimes you might see that there's hemorrhage in the back of the eye, and it's important to recognize retinal hemorrhages are more easily seen on MRI, but even MRI is not very sensitive. But if you see it, you have to mention it. When you have bilateral, numerous, extensive retinal hemorrhages in a patient where you're suspecting child abuse, that is highly suggestive of the diagnosis, and it will support your diagnosis. So it's important to pay close attention to those small findings. Another important aspect that I want to emphasize is just pay attention to the anterior chamber. Look at the anterior chamber on the left side here. There is a change in depth, in that the anterior chamber is almost non-existent on the left side. And this is because there is a rupture of the globe, right? So you have decreased pressure anteriorly. So this is an open globe injury. In this other patient, you can see the opposite, that there's an increased depth of the anterior chamber on the right side. And this is another patient who had a posterior globe rupture, right? So there's prolapse of the lens, but the change in depth is important to recognize. Now, this is an obvious rupture of the left ocular globe, where you have this sort of a flat tire appearance. And here you can see an example of hyphema. Hyphema represents hemorrhage in the anterior chamber of the eye, and blunt trauma is the most common cause. Now, CT is not sensitive for it, but it's one of those findings that you may sometimes see if you are paying attention to the anterior chamber. Here you see the right eye where there is hyperdensity in the anterior chamber. So that represents hyphema. Compare that to the left eye where the anterior chamber looks normal. And this patient happened to have CT for another reason. And you can actually see the hemorrhage in the anterior chamber. On the T1 non-contrast appears bright. On the flare, it's also bright. And you have accompanying restricted diffusion. And we're going to end up with a couple of potential pitfalls. And here is the first one. This is a very homogeneous hyperdensity in the left ocular globe with this very well-demarcated interface posteriorly. If you measure the Hounsfield units, those are your values between 110 and 130. So this is a typical appearance of silicone oil. Do not confuse that with ocular hemorrhage. This is hemorrhage of the right globe in a different patient. This is more irregular. It is hyperdense as well, but it doesn't go higher than 800. And you typically will find other causes of trauma. This is another patient with hemorrhage in the right ocular globe. And again, you can see some findings of trauma. This is a patient with axial myopia. You can see the increased AP diameter of the globes, and these are globes where the sclera is more thinned than usual, and they are at an increased risk of rupture. How about orbital emphysema? This is a typical case of orbital emphysema. It might happen from trauma with or without the presence of a fracture, or it can happen spontaneously after forceful sneezing. We've had cases of that, but it's important to recognize that pattern. Now, compare that with this other patient when you have air within the globe. And again, similar to the case of silicone oil injection, this one looks very homogeneous. And what this represents is an air tamponade. And this is used for treatment of retinal detachment, similar to the case of silicone oil. And this patient also has a scleral buckle. But just remember that appearance, right? It's very different than orbital emphysema. Now, the air in the globe will be resorbed in a different time depending on what gas was used, right? So you can see it anywhere from 1 week to several weeks, but that will be resorbed over time in most patients. So take home points, just remember the trapdoor variant that we talked about, right? That may be a little bit difficult to identify. Pay close attention to the anterior chamber. Always think about anything that may result in mass effect within the orbit that could potentially lead to orbital compartment syndrome, which can lead to orbit nerve ischemia. And remember the appearance of silicone oil injection. Do not confuse that with hemorrhage. And also the appearance of air tamponade for the treatment of retinal detachment. And with that, I will finish here. Thank you very much for your attention.